So good morning, everyone. I hope that you enjoyed yesterday's program and also the evening program. And I see that still many people probably will come later. And also my colleague Peter Nougel will come a bit later because he's in traffic jam. And we have the last day of this meeting ahead, and is dedicated to cardioinhibitory syncope or inappropriate sinus tachycardia, basically to modulation of autonomic nervous system of the heart by ablation. So another interesting, let's say, field of catheter ablation business. And it's my pleasure to invite the first speaker, who is Roman Piotrowski from Warsaw. This is a center which I have long-term cooperation with, thanks to Piotr Kulakowski, who is head of cardiology there, and they do procedures as we do in Prague. So it's a pleasure to have Roman here, and he will talk about current evidence and ongoing studies in this field. Roman, please.
Good morning, dear Chairman, dear colleagues. Firstly, I would like for inviting me. And today I'm going to talk about current evidence and ongoing studies regarding cardioneuroablation. But first, I would like to remind you the concept of cardioneuroablation is because, as you probably know, the target of cardioneuroablation are ganglionated plexi located around the atria. So the GPs contain parasympathetic postganglionic bodies and sympathetic and sensory fibers. And during cardioneuroablation, all of these parts are damaged, but there is one difference because the parasympathetic nervous system does not regenerate, while the sympathetic and sensory system usually regenerates. So we can say that cardioneuroablation causes selective parasympathetic vagal denervation. Let's go further. And what is current status of cardioneuroablation? Because we know that current status of cardioneuroablation depends on available data. So based on the literature, we can find in the literature numerous case report and case series, a few studies with control group but non-randomized and retrospective, 2 small randomized prospective studies, 1 small randomized prospective animal study, a few randomized technical reports, 1 big meta-analysis, 1 big report on controversies in cardioneuroablation, a few review articles, and the last one, the scientific statement, which was announced at last ERA Congress and will be published soon. So that is our data which are available. So let's start a review. So the first study I would like to show you is cardioneuroablation for vasovagal syncope. This is one of the most important studies because there is a first randomized study comparing cardioneuroablation versus non-pharmacological treatment according to the current guidelines. And as you can see, this study showed that cardioneuroablation is definitely better than non-pharmacological approach because the efficacy of cardioneuroablation was 92%, while the efficacy of the non-pharmacological treatment was only 46%. But there was one finding, because another finding also more important is that the cardioneuroablation also improves quality of life. So the main conclusion from the study is that cardioneuroablation is better than non-pharmacological approach, and cardioneuroablation improves quality of life. The second indication for cardioneuroablation is functional sinus node disease, and I would show you a summary which showing that in patients with functional sinus bradycardia, cardioneuroablation significantly increased sinus rate and heart rate, so which means that the patient lost indication for pacemaker implantation. So there is another indication for cardioneuroablation, and the third indication for cardioneuroablation may be also functional atrioventricular block. So here I would like to show you 2 studies. First study is observational study conducted by Tolga Aksu, and as you can see, in well-selected patients with functional atrioventricular block. Cardioneural ablation also is a very efficacious procedure because the efficacy of cardioneural ablation is about 90% in follow-up lasting 19 months. Now I would like to show another study which was also announced at ERA Congress recently. It was multi-center registry. As you can see in this registry, 130 cardioneural ablation procedures were performed with acute procedural success about 96% of cases, but efficacy during median follow-up lasting 300 days, the efficacy of cardioneural ablation was about 77%. So as you can see here, for inpatient with functional atrioventricular block, cardioneural ablation may be also an option, and the patient may avoid pacemaker implantation. But as you saw, I have presented only studies favorable to cardioneural ablation, but currently the discussion about cardioneural ablation focuses on two main aspects. So the most frequently raised topics which are discussed are post-procedural inappropriate sinus tachycardia after cardioneural ablation and lack of vagal protection in future of life. So now I would like to show you the data which touch this topic. So the first study I would like to show is a study from my center. In this analysis, we focused on side effect after cardioneural ablation. So in median follow-up lasting 26 months, the side effects occurred in 13% of the patient, and they were dyspnea, chronic chest pain, decreased exercise capacity, and transient palpitation. So as you see, all the side effects are usually transient. However, look at the last point. In 7% of the patient, inappropriate sinus tachycardia also occurred. So we should keep in our mind that after cardioneural ablation, most side effects are transient, but inappropriate sinus tachycardia may also occur. So in this patient, or beta blocker or ivabradine may be needed to slow the heart rate. So the second study I would like to show regarding safety of cardioneural ablation is another important aspect is deprivation of protection of the vagus nerve, because this study, as you can see, that was a randomized animal study conducted on the pigs by Shiv Kumar group, and pigs underwent cardioneural ablation, and after six months after cardioneural ablation, one group of the pigs has been induced ischemia by ligation of LAD, and in this group, as you can see, occurred more incidence on ventricular fibrillation, more shorter time to NSVT and VF, more episodes NSVT or polymorphic NSVT, and increased PVC burden. So maybe that's a sign that cardioneural ablation is not a safe procedure, so maybe also be prioritic in the future when the sudden ischemia occurred. But on the other hand, I would like to show another data because in my opinion that is very important data, because showing that during normal standard PVI isolation we may obtain, using normal standard RF energy, we may obtain total vagal denervation in over 90% of the cases, but there is still no reports on increased arrhythmic mortality during over 25 years when AF ablation has been performed. So as you can see, the data are inconsistent. So we need more data, and we need a longer follow-up to determine the safety profile of cardioneural ablation. And the next issue I would like to show you is, because there is still no consensus which approach is the best. It could be right atrium approach, left atrium approach, or maybe bilateral approach is the best. So I think our study brings us some answers for that, because that was a randomized study from my center, and in this study the patient were randomized into two groups, to cardioneural ablation only in right atrium or cardioneural ablation only in left atrium. as you can see below, in the right atrium group only, the complete vagal denervation was obtained in 35% of cases, while in the left atrial group, the vagal denervation was obtained in 80%. But what is most importantly, excluding anatomical aspect such as sinus rhythm or during mapping sinus node or sinus node at SPSGP or phrenic nerve at SPSGP, all crossovers were due to the persistence of AB blocks. So maybe it means that right atrium approach or left atrium approach is enough to obtain sinus node denervation, but it's not enough to obtain complete vagal denervation and atrioventricular node denervation. And our findings, our results confirm these findings from the large meta-analysis, which show that LA approach or biatrial approach is associated with better outcomes than right atrium approach only in patients who underwent cardioneuro ablation. And here you can see all studies from the clinical trials, ongoing or registered study, because there is 21 studies registered in clinical trials, but we should exclude 5 studies which are completed. So there are only 16 ongoing studies registered in clinical trials. But what is most important, what answer will the studies provide? So the first question is cardioneuro ablation, whether cardioneuro ablation or placebo or maybe sham procedure is better. So this study is ongoing. We are still waiting for the results. The next question is comparing cardioneuro ablation versus pacing. This study is also going, so we are waiting for the answer. The third, cardioneuro ablation or maybe drugs like theophylline in functional atrioventricular block or midodrine or fluorocortisone is better than cardioneuro ablation. So this study also ongoing, so we are waiting for the results. The fourth question, right atrium versus left atrium or maybe biatrial approach is better. We don't know. This question is partially done because our study showed that left atrium is better than right atrium, but there is no study comparison to compare right atrium versus left atrium versus biatrial approach, and there is no evidence about complete versus incomplete vagal denervation measured by extracardiac vagal stimulation, and there is no data about very long-term follow-up after cardioneuro ablation, because as you know, we need this data because very long-term follow-up is necessary to determine the safety profile of cardioneuro ablation. The next, this is the summary slides, which showing what do we know and don't know. This is from Clinical Controversy, published last year, and as you can see, we know that the best candidate for cardioneuro ablation is the patient with asystolic reflex syncope documented by a Hood or ILR. We know that cardioneuro ablation is less suitable in the mixed form of vasovagal syncope, and we shouldn't perform cardioneuro ablation in vasodepressor forms of vasovagal syncope. We know that the main target are paraseptal ganglia, but we don't know whether we should ablate all of this ganglia or just maybe SPSGP for sinus arrest or maybe IPSGP for the AV block. We don't know it. There is also no consensus about approach because we don't know which approach is the best. Maybe it could be array approach, maybe LA approach or bilateral approach. There is still no consensus about optimal ablation technique. We don't know how to assess the acute procedural success. And we need, of course, little is known about long-term efficacy because reinnervation may occur after cardioneuro ablation. Little is known about patient expectation effect, and little is known about physician expectation effect. So we still need large randomized control trials and need a longer follow-up to determine the safety profile and to know what is potential harm of long-term vagal denervation after cardioneuro ablation. And that's the summary. I choose this slide because, as you can see, the authors are mixed because Tolga also is fan of cardioneuro ablation, but there is also Carlos Morillo and Richard Sartor who are more skeptic. And they also agree that cardioneal ablation should be limited to the severe patient with severe, unpredictable, and recurrent vasovagal syncope who has cardioinhibitory mechanism of vasovagal syncope. And they divided the patient into two groups. The youngest patient under 40, they claim that cardioneal ablation should be the first option. Of course, if atropine test is positive. The second group, the patient between 40 and 60, is a gray zone. So in this patient, the approach, the therapy should be individualized. And the third group, the patient in age over 60, we should rather think about pacemaker stimulation. However, in my opinion, the crucial role plays atropine, because if response to atropine is adequate in all of these groups, so I think we may offer cardioneal ablation in all these patients as a first option. So thank you for your attention.
Thanks, Roman, for a nice overview of current evidence. Any questions or comments?
Actually, you mentioned unappropriate sinus tachycardia, which is may be the issue. What would you recommend in that respect? Okay, when you go for sinus node ablation or directly, or
This is hardly to say, because usually we try to avoid sinus tachycardia, especially when we do functional AV block. But sometimes it's not possible to avoid ablate also higher ganglia. So we can't predict this because there are no data.
actually we have two cases, the young ladies. And it's really like a big problem. It was really worse than before. And when we got sinus ablation, they are really candidate for pacing then, because you cannot do any other ablation then, right?
Yeah, that's true. So. In our center, the first step is always beta blocker or ivabradine. So
have you seen have you seen some in your cases some unappropriate sinus tachycardia? Or
But usually it resolves during the follow-up. Let's say during the first year.
No action,
And
no ablation.
we have no single patient who required any interventional treatment for this. And we are only few, I would say maybe out of 270 cases, we had only maybe 2 or 3 who are a long time on beta blockers. And I think we have only 1 patient on combination of beta blocker and ivabradine. And in terms of prevention of this, it is possible it's difficult to titrate the amount of energy delivered to the superior ganglia during the procedure. But there is one predictor which can be helpful, and it's the response to atropine test. If there is a huge response and it's done in all patients, it's like sign that you should ablate less, because if you ablate less, even if you achieve complete innervation, there is a huge potential for recovery. And even if the patient is very symptomatic during the first month, second month, there is huge potential to recovery of parasympathetic innervation, and of course alleviations of majority of the symptoms. Of course, this is associated with more chance for syncope recurrence, but it is always better to re-ablate in such a case than to ablate heavily from the very beginning.
Okay.
We have one patient with very symptomatic inappropriate sinus tachycardia. The pharmacological treatment failed, and we did 2 modifications of sinus node, but it was also unsuccessful. So the patient now had pacemaker implantation, because after 6 months after sinus mode modification, symptomatic bradycardia occurred again.
Did you perform, or would you think about another
Another cardiorenal ablation, no, because there is no response to atropine. So
Okay,
the
clear.
patient was completely denervated.
I wonder, what is your opinion? Do we need test like extracardiac vagal stimulation for all these cases? Because in my opinion, this is clear endpoint of the procedure, or,
Yeah.
or just to do it like empirically, or like many people do, or just look at heart rate, increase after.
In my opinion,
procedure?
extravagal stimulation is clearly an elegant endpoint, but there is one problem because the stimulator is not available in all centers. So the availability is limited, I think. But for the beginners, I highly recommend ECVOS because the people who start to do cardiorenal ablation, so see immediately the effect of action.
I like your, let's say, opinion about this safety issue, because you nicely show that there are thousands of AFib ablation procedures where you always do at least a partial neural denervation,
exactly.
and there are no signs of, no warnings that there is some proarrhythmogenicity or something like that. And we do it mostly in population like 60, 70 plus. So it's really reassuring, in my opinion, although it's indirect evidence. But I would not be so much stressed by this.
But the study conducted by Shiv Kumar showed maybe this warning sign for us, but there is animal study, and we don't know how to translate this result into the human.
Exactly.
And we should also keep in our mind that herd of the pigs are more sensitive
exactly.
for induction of BFI.
It's completely different scenario, but also people sometimes forget that to implant pacemaker is also not just without any potential harm. So especially if you would implant the younger patients, so I think neuroablation is clearly alternative, which in my opinion is more appealing, especially for younger population. But even as you said, in the age between 40 and 60, even 60 plus, if there is a clear-cut evidence that it's functional, so I would still rather have neuroablation than pacemaker implantation, because pacemaker has a lot of potential side effects, and it's not like taking pill or not taking pill.
So no any age limitation, right?
Yeah, I think atropine should be.
Give me atropine, I will respond.
You don't need atropine,
So
you respond all the
ablation.
time. Okay, thanks.
Only short comment when you start speaking about atropine. It's very nice to, but the difficulties with atropine testing is that nobody knows what is normal. Of course, there is sort of kind of established physiological response plus 25% of the baseline heart rate, but this is clear nonsense, because you may imagine if you have patients with basic rate 60 and plus 25%, it is 75. And elevation from 60 to 75 is definitely not good response to atropine. So nobody knows what is positive and what is negative.
That's a good point.
Okay. Well, thank you very much, Roman.
Thank you.
And we continue with another talk about neuroablation, unilateral or bilateral approach. Dan Wichterlev from ICAM in Prague.
You said ICAM or ICAM?
ICAM is in Czech, in Anglo-Saxon say ICAM.
So, dear Chairman, dear colleagues, after the elegant review of all studies given by Roman, I have a chance to give you, let's say, more focused and deep insight into any specific responses or specific responses to of some ganglia to cardio RF ablation. And I have to apologize because I only slightly redesigned the lecture that I had at ERA meeting in Berlin 3 weeks ago, but since then there are no new data, so I had no chance to modify or add something new. I will start with this systematic review and meta-analysis that was published 2 years ago by Carlos Morillo group, and it appeared that right atrium ablation is inferior to either left atrial ablation or biatrial ablation, but the reliability of such a data are pretty low, because even if it was quite large meta-analysis, 14 studies, almost 500 patients, all these were, these populations were pretty heterogeneous, were ablated by different operators with different strategies, technical strategies, and also follow-up was different. So I don't consider these data, even if it already indicate the right atrial ablation was had a lower efficacy, I don't consider this reliable. We would like to have such a data. The single right atrial ablation appears to be rather effective, as demonstrated by Belgium group, by Philippe Debrine. And we want to compare it to this strategy, because and it's logical that if you have nice efficacy by this strategy, if you add some lesions from the opposite side, it may only increase the ablation efficacy, not decrease. This is another meaningful comparison, comparing the left atrium alone ablation to biatrial ablation, but this is not what we need to know, because if you start ablation on the left side, it's very simple to go for right atrium and complement the ablation. And so this comparison is of more clinical importance, because when you start with this relatively simple and low-risk procedure, it is more difficult than to continue with left atrial ablation, because it is against the simplicity of this right atrium approach. But we have no data on both, no data for this, no data for this. What we have is this direct comparison of right atrium versus left atrium, and no biatrium. And there are 2 studies on this, and I will try to demonstrate them. Both of them use this extracardiac vagus nerve stimulation. And for those who are not aware or don't know this nice procedural endpoint, this is the method when both internal jugular veins are engaged by catheters up to the base of cranium, to the outlet of the main stem of vagus nerve, and are stimulated by special protocol using high output and high frequency. You need this dedicated cardiostimulator. By the way, there are other companies who produce this one, not for this use, definitely. This is again off-label use, but there is UK-based company Digitimer that produces a lot of types of neurostimulators that are used for transcutaneous nervous stimulation by neurologists, and definitely this can be connected to our catheters. So this is the way how to have at least some certified device, because this is certified, but not for this. This is off-label, but it can supplement this passion neurostimulator. And what can be observed physiologically after the stimulation is either a long sinus pause or AV block if the atria are paced simultaneously, and it is physiological response. And by repeating this investigation during the procedure, during the advancing the cardioinhibitory, we see the attenuation of all responses until we reach the complete non-responsiveness to both right and left vagus stimulation. and also think that increase the sensitivity of this measure because right vagus is more specific for a sinus node and left vagus more for AV node. So this was used in both studies. This was the first one that exists only in abstract form. It was not published yet. And we compared two strategies. Right atrium, you see the lesion set at the posterior aspect of right atrium SVC junction. And this lesion from the right anterior vestibule of right superior vein. And you see here in biatrial mapping that these lesions are pretty contralateral. And what we have seen subsequently is that effect of both lesions are plotted for sinus arrest induced by extracardiac vagus nerve stimulation. And you see this is for right atrium ablation first. This is for this should be left atrium. This is left atrium ablation first. And this is a small study, only 12 plus 12 patients, but these box plots already indicate that after left atrium ablation, there is significant drop in vagus responsiveness corresponding to right atrium, and this is even more prominent when we look at the blind plots, again for both strategies, right atrium first and left atrium first, and you will see that this strategy, there is a lot of patients with like almost no response to ablation when it started at the right side, while when we started at the left side, at left atrium, there are only 2 of them who were not yet completely denervated in terms of sinus nodal denervation. So this is in favor of left atrial ablation. And the second study, it was already shown by Roman, and so I will not go, maybe I just repeat that they did something comparable using extracardiac vagus nerve stimulation, and they observed that after right atrium ablation, they achieved only 35% of denervation of final success, and the efficacy of left atrium ablation was much higher, 80%, and it was statistically significant. But I also should add that this study had some limitations because it was spoiled by the fact that not in all patients right atrium ablation was performed because of some observation either for proximity of phrenic nerve or proximity of sinus node or some other concerns. So it was this is limitation that may induce artificially some like false, even if some false inferiority for right atrium ablation. So this clear limitation. But anyway, it again indicates that left atrium ablation is probably more strong than right atrium ablation. So these are studies for, so I close this topic and we go for AV nodal denervation, which is much more difficult because there is a lot of inputs into the AV nodal area, and usually the most effective site to denervate the AV node is to ablate this pyramidal space. It is not pyramid here because this is 2D view, of course, but this is triangle here and here. And it contains a lot of fat and a lot of ganglia that are named, this ganglionic site is named posteromedial left, or in our new, in our article we call this inferior paraseptal ganglionic plexus because maybe it's more reflect the reality because it is not left, it is not right. And it can be targeted from 3 sides, from the bottom of left atrium here, from the proximal coronary sinus, and from this posteroseptal segment, very inferior segment of right atrium. And you see on these ICE images how we target this posteromedial left ganglionic plexus. This is from left atrial aspect. This is from right atrium aspect, and obviously I have no slide for or no video for coronary sinus ablation. And in this small study, we compared two approaches. We started either with right atrium followed by coronary sinus, or with coronary sinus followed by right atrium ablation, and left atrium ablation was the last step, non-randomized. And here are the results. So there was nine, and again, this is response to extracardiac vagus nerve stimulation. So after coronary sinus ablation, there is huge attenuation of the response. After right atrium ablation, this is this side. It appears that it is almost ineffective. But when combined, this has some additive role to coronary sinus ablation. So when you start with right ablation, you have almost no effect. When you add the coronary sinus ablation, you go at least to the same side, like irrespective of the order, irrespective of whether you start in right atrium or coronary sinus, the final effect is here. But this is not complete AV nodal denervation in all patients. And finally, we have to proceed to this side. And again, this was not completely denervated in absolutely all patients, but this ablation at the bottom of left atrium has, again, additive role. So all three clusters are important for AV nodal denervation. And these data are new, were demonstrated at a moderated poster session at ERA. And this is a response to, just to show if the strategy that is used in this Belgian group by Philippe de Bruyne is all right. This is the direct comparison of two strategies. The first strategy is to ablate only from the right atrium and with the huge ablation index, just to have large lesion to be able to penetrate through the ganglia or maybe even deeper. So this is one strategy that, and of course, in such a strategy you can avoid transeptal access. And we try to compare to the pretty same strategy, and we ablated 400 from right and 400 from the left. It should have comparable results because there are two lesions of like half dose or half deep, and this is what we have found. So left-sided, right atrium ablation only, de Bruyne approach. And you see on this box plot that there is no complete denervation. In some, of course, definitely in some patients, yes, but not in all of them. And this is box plots for biatrial ablation. This difference is not statistically, this is formally numerical difference, but not statistically significant because we enrolled only 11 plus 11 patients, but we continue enrolling. But maybe these box plots are more illustrative. So using the de Bruyne approach, 3 out of 11 patients were not denervated. Sinus node, and I don't speak about AV node, it is even worse. I speak about sinus node. So sinus node was not denervated in 3 patients, while there is consistent response by atrial response, by atrial ablation. So I am pretty close to the end of my presentation. And I want to conclude that biatrial cardioinhibitory ablation offers more degrees of freedom. This was the subtitle of this presentation. I'm the protagonist of biatrial ablation. All presented findings complement the notion that the biatrial ablation is more effective than standalone right atrial ablation. However, these observations relate to acute procedural effects. We don't know if it relates to long-term denervation and maybe even less relate to clinical outcome. We don't know. Definitely, right atrial ablation is likely superior in terms of safety, but it was not investigated. Thank you.
We will follow, thanks very much. We will follow with discussion immediately because both guys have to go to the lab and do live cases, and we will then continue with some other presentations of this session. So any questions to Dan or comments?
You know, Dan, I always thinking, is it any ratio to still thinking about like only right-sided? What is the complication rate? Is too high to get no any biatrial approach?
I think that
We
in
have
some,
thousands people like for atrial fibrillation ablation. Now we are talking about this and this.
yeah, but
It made no sense, right, people?
No, I think it's mostly my understanding is that some people who are more conservative, they say that we don't need to do really a complete denervation because we don't know what it will do in the long term. So that's more like a safety issue, to minimize damage, not to that they are afraid to go to left atrium.
But we have, my feeling is vice versa because, well, we need more than less.
Well, we know, you never
Because
know.
it's always in growing,
But
right?
but I really pick up Roman's view that there are really thousands of patients who underwent thermal energy ablation of atrial fibrillation, and we really have no signs of no safety warning that it does something really. Some patients may have inappropriate maybe sinus tachycardia, but it's very rare, which is mostly asymptomatic. So that's for me a bit reassuring, and we know this for 25 years actually. We did first ablation here 25 years ago, exactly 25 years ago, first ablation of AFib. So that would be, if this is so harmful, that would be already visible, I think.
and I also always comment that if it is true that this is dangerous in terms of these ventricular arrhythmias, we are mass killers because it was. This procedure was done in millions of people.
Yeah.
So,
Exactly.
and I agree that it is nice to have like very extensive ablation from both sides and to reach the complete innervation. But the concern is that maybe it is not needed in all patients, and there is always all the time there is possibility to like re-ablate. So maybe this right atrium ablation is not so bad concept.
Okay. Any other questions from other? Go. No one. Nobody. Okay. In that case,
Thanks. So
please,
we see you
guys,
soon.
see you soon on the
On
screens,
TV.
right? Okay. Thank you. Okay. So we have third lecture. Cardioneuro ablation from the neurological point of view. It's Alexandra is here. Alessandra, right? Alessandra. And how to say, like, Alessandra Fanciulli or Fanciulli?
Fanciulli. That's perfect. That means
very nice, okay.
That
From
means
Austria, Innsbruck, Südtirol, right?
yes. So Innsbruck is in North Tyrol, so we are in Austria, not in Italy anymore, but I have Italian origins. And fanciulli means children in Italian. Children.
Oh,
yeah,
very nice.
Exactly. Thank you so much for starting.
So we ask Alessandra to give some balanced view from a neurological point of view, because neurologists maybe are not so aggressive like cardiologists. So just to give some balanced view of both.
Be nice to
views,
see if she is happy about the two talks, right?
Oh, well, there were excellent talks, and actually very balanced also from the neurological point of view.
Thank you.
Well, you must be balanced when you have this disease. So,
actually, we need to discuss after the talk, right?
I know.
But anyway, thank you for your invitation to join Prague Rhythm today. It is a pleasure for me to see that there is this bridge, that this back and forth of communication between cardiologists and neurologists. This was also the case during the first clinical controversy, which was already shown by Dr. Wichtele, and which has been going on now for the consensus work, which I took part in. So I would like to start today with a semiological pearl from YouTube. You might ask yourself, why do people post this kind of things on YouTube?
my goodness. We're gonna... Oh my goodness.
Of course, the environment is also a primer. If somebody can let me know what kind of music is playing in the background, I will be very thankful.
Katie? Yeah.
Go ahead and lay down, okay?
But now, back to our medical task. So what happened to this young lady getting a piercing? What was that? Was that a seizure? Was that a syncope? Or a psychogenic spell? Or none of the above? So who is for a seizure? Who is for a syncope? Psychogenic? None of the above? Excellent. So, of course, we are all very skilled, but this is to make the point that the proper treatment starts with a proper diagnosis. And this is one of the tasks which we as neurologists have, to properly distinguish between syncope, sometimes convulsive syncope, so she had some myoclonic jerks, and psychogenic spells, which would require a completely different treatment. So always be alert and question the diagnosis if this was not you to make this diagnosis. And by definition, we know a syncope is a transient loss of consciousness due to global cerebral hypoperfusion. We saw that lady was turning pale while she was fainting, and it is characterized by a rapid onset, a short duration, and a spontaneous, a complete recovery. Now, we know the ultimate mechanism is this low global cerebral hypoperfusion, but which are the main causes of syncope? Cardiac causes, so the cup of tea of my colleague is from the cardiology department, syncope due to orthostatic hypotension, and reflex syncope, of course, the focus of our talk today. In reflex syncope, we have an aberrant activation of the baroreflex arch due to some specific triggers. Could be hemodynamic triggers, but could also be emotional triggers or somatic triggers. In this lady, it was a combination of pain and maybe fear. And this leads to an acute sympathetic withdrawal of the stimulation to the blood vessels, which produces a vasodepressor effect and a vasodilatation, or an acute excessive cardiovagal activation producing bradycardia up to asystole. Most frequently what we have is a mixture thereof. So what is the therapeutic gold standard? We are still back there in 2018. And it says that once you have diagnosed a reflex syncope, especially if this was the first syncope episode, which every third person in this room will have on the CV in the course of life, the first therapeutic step is to go for education and lifestyle measures. This is in clinical practice a bit more easier said than done, because you don't know exactly how to talk to the patient and how to make this person take it seriously what you're advising. And there's a small tip for you. So colleagues from Leiden in the Netherlands developed a very nice video, which I frequently use in clinical practice, because this helps take away some anxiety from the younger people. I would like to show this to you.
Diagnosed with vasovagal syncope? What is it, and what should I do? I feel very hot, I feel dizzy, and suddenly everything goes black. To faint is not unusual. Almost half of the population will faint once in a lifetime. Fainting can be frightening, but can be managed. Fainting can occur at any age, but is more prevalent in young people and the elderly. It can happen when you stand still for long periods, for example, at the supermarket checkout or at a concert. Other triggers can include pain, fear, or shock, for example, blood tests, or even the sight of blood. A sudden drop in blood pressure can cause you to faint, because this results in blood pooling in your legs. If your blood pressure is too low, you can feel dizzy and faint. Fainting is not life-threatening, but can impact on work, school, home, or other activities. To prevent fainting, there are counter-maneuvers if you experience pre-syncope symptoms. Do not ignore these symptoms of feeling hot and dizzy. It is unlikely they will go away. Sit or lie down immediately. This is the fastest way to increase blood pressure and stop the symptoms. Immediate action to counter fainting if standing includes clenching your buttocks and tightening calf and thigh muscles, which will return blood flow to the heart. Other tips include crossing legs and squeezing calf muscles together tightly, which can be done both sitting and standing. If this does not help, then lie down flat with legs raised. When you feel better, get up cautiously. Do not rush, otherwise your blood pressure may drop and necessitate you lying down again. Prevention is important, so drinking 2 glasses of water quickly before an event that involves standing may help. High fluid intake, together with extra salt, can help symptoms of low blood pressure, not applicable to high blood pressure. Follow this advice and you will be confident should you feel faint. If you are fainting more than once or twice, then visit your doctor. Fainting is a symptom, not a condition.
Exactly. So in the case of recurrent vasovagal syncope, then there is the indication for follow-up examination, and then we need to know which is the underlying hemodynamic mechanism. This was the classic classification into vasodepressor, so blood pressure fall beginning before the fall in heart rate, a mixture of both, or predominant cardioinhibitory with or without asystole. Why is this important? Because this will guide the therapeutic approach. This is again back from the 2018 guidelines, and so we distinguish between in younger people a low blood pressure phenotype, or in elderly people maybe a too tight blood pressure control with drugs, where you would like to raise the blood pressure. So your first target will be the blood pressure. We have trials which say that for the low blood pressure phenotype, both fludrocortisone and midodrine have a positive effect. The problem in younger people with midodrine is that they are not very keen on taking a medication 3 times a day each day, so the compliance will be very low. And so you need to highlight which these people would profit for this kind of therapy are. In this case, what would really help you would be a oldie but goldie, a 24-hour ABPM, because Michele and Arthur and others showed that when on the 24-hour ABPM you have this hypotensive episode, so below 90 or below 100, you have a high diagnostic accuracy for identifying this hypotensive susceptibility. On the other hand, we have the cardioinhibitory type, and the older the patient, the stronger the indication for cardiac pacing. However, our main problem are actually the younger people, because these people are young, are active, would like to practice sport, and we need to take care for 40, 50, 60 sometimes more years of life. And so implanting a pacemaker is not a trivial thing, because of lead disruption and sports and trauma and so on. And so we have this new therapy which I've been hearing about, cardioneuroablation. Rising interest also from the neurological side. But what we know and what we don't know at present, which is the proper candidate? Of course, people with a documented asystolic reflex syncope, either on the head-up tilt or with a loop recorder. But there's a but, and this is something which the neurologist would like to see. I will show you a case from our lab. Maybe you're familiar with this kind of tracing, so this is just a video of the patient. This is an ECG, and here you see on the upper part the oscillatory blood pressure measurements, and this is a continuous blood pressure monitoring. I will already disclose to you that this patient has a vasovagal, so orthostatic trigger vasovagal syncope of cardioinhibitory type with a systole. However, there is an important thing to notice. So please have a look and then we'll discuss. So he's now telling that he does not feel fine. And maybe you can already see what happens with the continuous blood pressure. The technician is asking, so can you manage a few more minutes? Can you manage a few more seconds? But then he has to be tilted back. And now have a look at the patient. and at the hemodynamic parameter. He's now unconscious. He has a syncope, eyes are wide open. He had some twitches. And now you see the asystole, right? He's still unconscious. Blood pressure is still very, very low. Not yet there, yet now he's there. Okay, so I think we agree on the diagnosis, right? I wrote the right diagnosis on the wrapper. But what is the peculiarity of this case? Please just speak out. Exactly. So the blood pressure was falling earlier than the heart rate. And when the asystole occurred, this person was actually already unconscious. So in real life, he would have been already gone onto the floor and had a head injury. And this is indeed what we observe sometimes, that in 1/3 of people who would fulfill the criteria for cardioinhibitory vasovagal systole with asystole, asystole occurs too late during the loss of consciousness to be the cause of this loss of consciousness. So when you're considering a patient for cardio-neuroablation, it would be important to have a tilt test examination with a video on top so that you are sure which is the timing of the hemodynamic events. The second thing that you as a as neurologists would really like to exclude before taking cardio-neuroablation into account is that we are not overlooking orthostatic hypotension or any form of cardiovascular autonomic dysfunction. That means either orthostatic hypotension due to blood pressure lowering drugs, but also CNS acting drugs, hypovolemia, some cardiac disease like aortic valve stenosis, or neurodegenerative processes involving the baroreflex arch, either the afferent branch, the central autonomic nervous system, or the efferent branch. The most frequent thereof worldwide is diabetic autonomic neuropathy. So because this is basically the very opposite of what we would like to treat with cardio-neuroablation. When you have a cardioinhibitory vasovagal syncope, you have a deceleration of blood pressure and heart rate, and what you see in neurogenic orthostatic hypotension is a deceleration in the blood pressure with a very blunted or even missing heart rate increase. And then I appreciate the atropine test has a high value in a diagnosis or in choosing the right candidate for CNA. Let's say the mirror, what you can do if you don't fully trust atropine test is go for a cardiovascular autonomic reflex test and see how the parasympathetic outflow to the heart is working. For example, with the Valsalva maneuver, I show you here. This is a healthy subject, and the thick blue line underneath is the blood pressure. The upper one, the thin one, is the heart rate, and during a Valsalva maneuver, you have first a slow increase in heart rate, which is due to cardiovagal withdrawal during the maneuver. And when the person starts expiring, you have a quick fall in heart rate, which is given by the cardiovagal activation. So if this reflex is preserved, then you can be sure that the vagus nerve is still working very fine. So in a person with reflex syncope, it will get you closer to considering cardio-neuroablation. Another thing, so this is the counterpart what you would see in a person with orthostatic hypotension. And another step which you would go for is deep breathing. So we read in these days a lot of studies about heart rate variability with fancy techniques, but a very old one and a very standardized one is a simple deep breathing, which you see here During inspiration, heart rate goes up, and during inspiration, heart rate goes down. And if you do this very slowly, like if you were practicing yoga, you will exacerbate this sinus arrhythmia, which is actually a physiological condition of our body. And you can calculate this, and you have, for this, you have standardized reference values, which of course are age dependent. And you can be sure the cardiovagal outflow of this person you are considering for cardiac neuroablation is fine, is working. There's no damage to that. So then the right side of ablation, this I will skip because my colleague already touched upon this, and verify the efficacy of cardiac neuroablation. Now the most data which we have is 2 years, and what we need to know is the outcome at long term. So what happens if we have neurite spreading, if you have, of course, if you have burned the soma of a neuron, this won't regenerate, but neurites can, so axon and neurites can, and so there might be some recovery. And of course, you need to have a look at the safety at follow-up. So what is the short-term and long-term safety? Procedure-related risk, we had a look at the literature, and it's not well documented. There are not much that are documented, but it should be, however, similar or even lower, because the radiofrequency time is lower, I understand, compared to AFib ablation than for established other procedures. It was already touched upon inappropriate sinus tachycardia, whether this will require some pharmacological treatment or not. It has been described that up to 1/3 of people undergoing CNA have it. How many will really require the ivabradine on top or beta blocker on top is not really known, but it is something which needs to be discussed with the patient. These are young people, and they need to accept that potentially they will have 1 pill a day to take. And then this is the part which makes us as a neurologist always very cautious about cardio-neuroablation, that cardio-neuroablation is a kind of a iatrogenic cardiovascular autonomic neuropathy. And in other contexts, the context of neurodegenerative disorders, we know that cardiovascular autonomic neuropathy is associated, so is an increased risk factors for cardio and cerebrovascular, both morbidity and mortality. So this is our main concern. We, however, know that in cardiovascular autonomic neuropathy, we also have a vascular neuropathic component, and we might have targets and organ damage, which does not apply to cardio-neuroablation. So the bottom line there, this is a potential risk, and we just need to monitor for this in all the patients which have been already treated so far. Fourth has been touched upon as well. So the vagus nerve is bad for causing all this vasovagal syncope, which might be associated with trauma and surely with distress in these people. Also has, however, a protective effect. The vagus nerve is the nerve of rest and digest, which helps our body to regenerate while we are sleeping. And what we need to know is what happens on the long run if we withdraw this, let's say, protective regenerative effect. So does this, for example, have an effect on hypertension and on specific condition which might show up later in the life of these people undergoing CNA, like myocardial infarction, risk of arrhythmias. So this was the key messages from the neurologist. And I would like to take the chance to acknowledge the hard work of all the people of the Innsbruck Dysautonomia Center who would like to take care of these patients. Thank you so much.
Can I have 2 comments?
Please.
In your video or your colleague from Leiden, it's the same like I reviewed some leaflet prepared by patient organization that syncope is basically nothing to worry about. If you have just one syncope, you just lay down, and if you have a recurrent syncope, maybe consult your physician. But I have to emphasize that syncope is a symptom which could be really like cardiogenic syncope. You know, first syncope could be, and you cannot say patients or people, syncope is nothing to worry about. You know, so if the syncope is, let's say, preceded with this typical symptoms, maybe you can say that it may be very benign, but always syncope could be warning sign that it's, for instance, aortic stenosis, if it's, especially if it's during exercise, could be arrhythmia, could be first arrhythmia which can kill patients, so could be second time which he will be killed by arrhythmia. So I'm always a little bit concerned that you say patient or population, syncope is, you know, nothing very special. You just try some counter action and things like that, and if it repeats, then you consult a physician. So this is could be very dangerous because you send message to people that syncope is nothing to worry about. And the other thing is that you said that TIL test should be done in all patients. There are studies showing that TIL test, even if you take healthy people and they never had syncope and you do a TIL test, you can induce I did many TIL tests in a long time ago, 30 years ago. When I was in UK, I did a lot of TIL tests with pretty boring stuff, you know, to do as a physician. But you see a lot of...
technicians do it for us.
Yeah, but at that time we did it because we were fellows. But you see a lot of phenomena, and it's really sometimes non-specific. So, and we also did some autonomic studies with heart rate variability, with this blowjob, using this, you know, Valsalva maneuver. And we've found that sometimes you have a blood pressure drop first, and sometimes you have this bradycardia first. So again, it is very functional, and it may not be always reproducible. So, you know, if somebody claims that this should be done always, and based on that you can guide therapy, it's nice theoretically, but in practice it may not be always the same. So I'm always against such a postulation like this works, this doesn't work, and it should be done by this and should be done by this. So these are just my comments, but I agree that many patients can be managed just you explain them what happens, and they don't need anything else. But we are also not talking about one first syncope. These patients who undergo ablation, neuroablation, these are patients who have debilitating symptoms. They have syncope every week sometimes. You know, we don't do ablation after one or two syncope during piercing or during blood test. Let's say taking blood for blood test. So these are my comments. Just, but otherwise I agree that we have to be balanced.
Oh, Sada, he's not so strong. Okay, take it like easy, right?
This is friendly discussion. I'm not saying that we should.
Would you like me to answer? Or
yeah,
not?
yeah, sure.
Answer me.
Well, I agree with you. So for the first point, so in the waiting room of my outpatient clinic, there are no flyers. So this video is something that I show to the patients after I have done my assessment. Because you're right, the first syncope, so one syncope might be enough sometime. So it is about understanding the prodromes, the context, the risk factors, the red flags for indeed a cardiogenic cause of syncope. But then the benign, the reflex syncope is ultimately the most frequent cause. And for these people, a very important step of the therapeutic approach is also to put it in the context, explain them, look, your heart is healthy, your conduction system is also healthy. That was the point. It was, if you want, it's an exaggerating physiological response to stress. And for these people, I think that this kind of video, I mean, it's just an example, or having a counseling is an important thing. I did not tell in the talk that we should perform a tilt test examination in all patients. For example, in the lady getting a piercing, we would have not needed that, right? But to understand which is the ideal candidate for more invasive therapies, would it be CNA or cardiac pacing, then you need to understand which is the underlying hemodynamic mechanism. And this, I'm sorry, but I can only do this with a tilt, or maybe with an ELR. But sometimes on an ELR, you have syncope episodes and no ECG correlate. You need to evaluate what happens with the blood pressure. And of course, we are in early days for us as a neurologist. I understand that CNA has been already established for more than 20 years or almost 20 years. For us are early days, and so putting this autonomic reflex test on top is an additional, let's say, safety measure, an additional information you would like to collect to be sure this is the real, the ideal candidate. Because there are some medical liability issues, and you want also to put yourself on the safe side that you're recommending the ideal thing, the right thing to the right patient. One more remark: if you have a patient which has weekly syncope, go back to the beginning and start rethinking of your diagnosis. Indeed, a high frequency of syncope, weekly or daily syncope, if there's no intercourse medical condition like an infection, for example, might be indicative of a psychogenic pseudosyncope, so of a conversion disorder, and so not the real person you want on your table, right? Okay?
Thank you.
Any other questions? We are a little bit over time, but then we need to take advantage. You are here.
We started a little bit later.
Okay,
But
no,
we have advantage that there is a flexibility during
perfect.
cases.
So you mentioned nicely the global effect of vagal. Okay, so I really like to have rest. Probably my vagal effect is so minimized, so I just sleep a little bit like shorter, right? But actually, the vagal effect global is like very important to get rest. I mean, digestion, whatever. Do you think that this CNA could produce that global response, a global effect, which I would be so surprised, first. And second, you mentioned neuropathy, potential neuropathy. What I a little bit like don't like, so is it potential risk for this, or from your perspective?
Yes, of course.
From my, it's
of
like
course. The peculiarity of the parasympathetic nervous system compared to the sympathetic one is that you have the preganglionic neuron, so the soma is actually in the brainstem, and you have this very long preganglionic axons, and then the postganglionic neuron is very close to the effector organ.
Right.
And what you're targeting with CNA are only the postganglionic there in the heart, so very selective. The point is, and under this point of view, you don't have this global effect, so from the procedure, but the one possibility, so, and I will tell you why we consider this, and we'll need to have a look at this in future years, is that when you have an increase in heart rate, the baroreflex will sense this.
Okay.
So to the brainstem and then up to the amygdala, anterior circular cortex, and insula will come a signal which says tachycardia, 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 while you should be resting and sleeping. And this is kind of a missense information which the brain receives from the baroreflex. We have learned this, so we are learning to understand the side effects of this in another cardiovascular autonomic disorders which arise dramatically after COVID, which is postural orthostatic tachycardia syndrome. I'm not sure whether you deal with POTS patients. So it's the most frequent cardiovascular autonomic disorder following COVID. It mostly affects young people, mostly female one. And we're studying these people, and a very frequent association which we have in this set of patients is sleep disorders. So there is, let's say, a shift of this baroreflex towards a sympathetic predominance, which in them has a bit of side effects also on sleep. In CNA, we do not know, but we just need to understand this, to monitor this patient and investigate that. And if you're running this casistic, you are on the best place to assess this or to exclude this, to prove that this is not the case. Neuropathy, yes, for example, in diabetes. So we know that in diabetes, so in diabetic neuropathy, this is a length-dependent process. And so the first nerves which are attacked in the autonomic nervous system, it is exactly the vagus nerve. It's one of the first to be attacked because it has this very long axons, right? And this has a detrimental effect. Also in other neurodegenerative disorders of the autonomic nervous system, we know very clearly this is associated with morbidity and mortality. There's, however, so in diabetes you also have this peripheral neuropathy affecting all the vascular tone, which you do not have with CNA, this you don't have. And you have a disease of the effector organ itself, so of the heart and of the vessels due to diabetes itself. So this is not a fully applicable, so you cannot make a one-to-one transposition of what we know in terms of epidemiological risk. But it's just something that we need to monitor over time, because this answer, I don't have this answer, you don't have this answer, time will give us this answer if we will monitor for that. So we need to look for that to be sure it is not present or it is present and the increased risk is so and so %.
Okay. Thank you. Okay, guys.
Very much.
Thank you, Alessandra. Thank you,
Welcome.
Alessandra. And then should we have a last talk? I hope it's on Zoom. Okay. So it will be.
Carlo.
Carlo is here. Is visible?
Yes. Can you hear me?
Oh, very nice. So, Carlo.
Yes.
So we just discussed the issue. So let's give us the talk. Okay. Thanks.
Yes, absolutely. I was online. I hear all the presentation. Thank you very much to allow me to present in this form, to participate on this beautiful Congress. And I apologize to not be there with you guys. So you put me in the hand to shock probably the audience. And I don't know why I'm only one invasive, but the point that in Brussels we figure out an alternative way to treat this kind of disease. I will try to advance. Yes, this is my disclosure. It's been said several times during the presentation, EST, it's not so uncommon. Most of the people do not see this patient because they are not referred to DP. And most of these patients are treated in another level and not on the electrophysiological level. So that's the reason many of the people do not face this problem if they are not specific treated, this patient. I would like to look back on our medical school, and if you see the conformation of the sinus node is very complex structure, and in this histological preparate, you can see that the sinus node is just an area, and you can easily identify this area, and you can also, if you go deeply, you can see that there is kind of extension. So, of course, the extension going inferior are the one that they connect to the crista terminalis, but there are extension going up to the SVC, and these are clear on the same nature and the same electrophysiological characteristic of the sinus node. Remember also embryologically, the sinus node is the last part that insert in the right atrium. So the sinus node is together with the SVC, IVC ostium are structured. They are actually insert in the right atrium to complete the form of the right atrium. And it's quite clear when you look anatomically the conformation of the right atrium. You can identify the cardiomyocytes coming from the primary structure and this sinus node plus SVC, IVC structure that they are insert in the right atrium. Of course, there is always discussion about, and honestly, I'm not agreed to identify only a neuro control of this problem. And that's the reason I put always the chicken and the eggs. I mean, the point is that there is for sure and maintain of this problem because everybody has the structure, and I make always the example of the slow pathway. So all women have a slow pathways, but not all of them come with a re-entry tachycardia. So I think there are mechanisms for sure relating on the neuro system that initiate, but what we find in our study is that there are other structure, electrophysiological structure that can probably maintain this problem. This was the advice of HRS Society in 2015. Of course, it's very important to figure out. I remember, I mean, syncope, sinus tachycardia, they are symptoms. They have to be really ruled out and figure out what is behind this problem. And of course, if you find the reason, then you have to treat the disease that is based on this problem. Ivabradine, in our experience, it works, but on the long term, that's the reason that we face sometimes patients coming back and complain after long term of Ivabradine. These young ladies do not support beta blocker. I don't know if you are more lucky than me, but beta blocker is something that I try all the time, but I can never maintain in this patient. And of course, the ablation of the destruction of the sinus node is not recommended for many reasons. But most of the problem is that transient permanent phrenic nerve paralysis is the main problem of ablation. And also do not underestimate the syndrome of superior vena cava. So you can provoke a stenosis of the vena cava. It been an approach surgical of destruction of the sinus node, and then of course the patient require pacemaker. I would like to remember that in this patient, when you come on the treatment, means that are patients that they do not have any quality of life. So I have young lady coming on the wheelchair on the consultation because are not able to walk from a parking lot to the office. And so these are the patients we treated. So even put a pacemaker in this patient, I know that is a procedure that can require long-term treatment and exchange and everything, but still a solution for them. So we point out pacemaker as a complication, but in some patients still was ease of the symptoms and improving on the quality of life. Anyway, we try to look the problem on the different way. And one of the reasons was that that was our first experience we did in 2019. Now, actually, it's 10 years we're running this program. One of the points is that in our center, we are quite active in a hybrid solution for arrhythmias. We have 2 sessions a week together with the surgeons, and that's what I like to show, because what for us, hybrid is really working together. As you see, you have surgeons and EP on the table. You can recognize that the surgeon is there because both of us, we have a mask that normally it's easy do not see during EP procedure. So now what we design, actually looking at from outside, we could identify these sleeves, these extension that I show you histologically before, and it was quite clear to decide to disconnect this extension, this electrical activation from the sinus node. That's the reason we call sparing of the sinus node. So we do an ablation around the sinus node, do not touch the area that I show you histologically to try to conserve the sinus node, to sparing effect. So these are just to show how of course, this is the potential of the sinus node you see on the left side. In this movie, I would like to show you the 2 catheter. Now, if you see there is one catheter up here, can you see my mouse moving around?
Yes.
Probably not.
Yeah.
Yes?
Visible.
Yes,
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 visible.
we can see.
Yeah, there is a catheter up to the, see almost on the azygos. And if you look carefully, it was a catheter down here on the, up to the sinus node. The sinus node actually is this fat area here. So these 2 catheter we use because you have to know that the mapping system do not help you during single lung ventilation. So the map are quite flat because they are impedance design, so do not work on a single lung ventilation and thoracoscopic approach. So we did some traditional EP. These 2 points so far from each other, they were on time on the activation. So as you see, there are a few centimeters between them, and they were on time on the electrical activation. That's, of course, push us to decide. And there is another point that you can identify with the map. That is the the limit of the SVC. You see this line here? When you map the right atrium with a traditional electronic anatomical mapping, the impedance of the ostium of SVC, it's the same of the right atrium. So when you map, you will never identify this line. Identify this line is crucial because you can identify where actually the anatomical structure of the sinus node is, following also the small sinus node artery. And then when you decide to isolate the SVC, you can decide to spare the sinus node. That's the reason that the surgery is crucial on board, not only to provide the protection of the phrenic nerve, but also to provide the lesion effective with this clamp. Actually, the lesion, as you can see here, moving the phrenic nerve away, of course, is one of the way to protect the phrenic nerve. It's quite crucial. But of course, isolate the SVC without touching the sinus node and identify the line of the sinus node epicardially with a visual camera. It's crucial because with the mapping, you will never be able to follow carefully. Remember that I show you a catheter up to the SVC that was early activated together in time with the sinus node. So that's what came out. So we decided to, following the early activation and the anatomy of the SVC sinus node, and then we decide to isolate the SVC, to disconnect the sinus node from the lateral part, and IVC also show some sleeves. That's the setting line is this way. And with this clamp provided by the surgeons, provide this line, it take less than 15 minutes. So the procedure himself, in expert hand, it can take up to half an hour, 1 hour maximum, if there is a difficult anatomy. Now, this was the population, the first. I remember, I mean, we not provide this for a first diagnosis of IST, of POTS. We provide this for a patient that they have and a long standing problem, that they are really debilitated by the disease and they try all treatments. So do not provide this for your first line patient. This is how it looks. In the beginning, we had many gastrointestinal reflux problems. That's also because during that we experience also with the hybrid procedure, because you move the heart and you actually affect also on the esophagus. So we do treat them now preventive. Pericarditis was surprising because in a patient, not so much pericarditis, probably due to the age, due to the fact that this patient has also a high immunoreaction due to the age, but also to the disease. And that's the reason now we prevent the pericarditis and don't have this problem any longer. As you can see here on the monitoring, we find also important to monitor them on long term to understand the disease himself. And then we implant most of them with Reveal. In the POTS patient is a small percentage of patient in our experience, but we didn't experience syncope any longer after the procedure. Then we had the multi-center that was done with many of all of them. They're American center, and we are the only European center at that time. Was a multi-center study. After the multi-center study, we did together with DJ Lucky Reddy in Kansas. We did the comparison with this registry between the catheter ablation and hybrid ablation, and then we show the superiority to hybrid ablation. That's lead us to the fact that we also propose some kind of mechanism that we for sure we provide a local denervation together with a disconnection of this electrical network that is around the sinus node. So we combine. It's a combined approach in our vision. Of course, that lead us to apply for FDA, and I'm happy to say that FDA accepted a single arm because not standard of care is recognized by the FDA for this disease. And that is the trial that was designed, called ELST, was published on Art Treatment H2, O2, and that is the design of the trial that is running at the moment. And the ratio, of course, is to prove the safety and the feasibility on the single arm study. So there are 40 centers. Most of the centers are in US, but we have also European center activated. At the moment, there is a UK, Belgium. There is a center in Poland started last week. And we are activating other centers in Europe. So the conclusion is that we would like to see, and of course the study will bring us reveal the result of this novel procedure. But this is an approach that can be considered in patients that they are really long-standing with this problem. And a multidisciplinary approach was the way that we find the solution probably for this problem, looking out of the box. Thank you very much for your attention, and I hope I saved some time for your delay. Thank you so much.
Thank you. Thank you, Carol. Okay, any questions? I remember our first epicardial approach with Vivek Reddy, and actually it was not surprisingly for VT ablation, it was for sinus node ablation. And we did it in 2001, I remember that. We never published that, but actually we were struggled by phrenic, okay? Even from, so what you nicely described the advantage. You can play with the phrenic, you can go from mapping and then atricular procedure. Would you like to stress the advantage of the surgical, or if we are able to get epicardially ablation, cardiac ablation?
Thank you very much for your question. I would like to tell you how this procedure is started. Actually, the procedure started with a patient that was strangled by the disease, and in the end, we decide to eliminate the sinus node and implant a pacemaker. And because we have this easy approach of the hybrid, and we have a program that is quite running every week, we decide for the best of the patient to say, okay, look, I discussed with Mark Lemaire, is my surgeon, and I prefer to do together with you because you can save the sinus node, but also, you can save the phrenic nerve, but it's very difficult to ablate the sinus node by catheter. So if you ever approach the ablation of the sinus node, many of the patients have recurrence to have, especially with, with a single catheter, it's very difficult to ablate the sinus node. So we decide to have a successful procedure for a sinus node exclusion, so sinus node destruction. We decide to go surgical. There are three approaches. So the surgeon can protect the phrenic nerve. The surgeon can avoid the SVC stenosis post-ablation. And of course, the surgeons can avoid perforation, or anyway, any complication can be by catheter ablation. So that was the 3 points that bring us on the table. And it was not about this procedure, it was about to implant a pacemaker and ablate the sinus node. The problem that when I was there, of course, as EP, I was tending to ablate, to map, and of course to understand. And when I saw the structure anatomically by the camera and electrical anatomically by the map, I could merge some information and understand further of this anatomy. And then, of course, we decided to following this early activation. And this line was possible to provide only by surgeons. So even if you want to isolate the SVC, it's quite challenging. And ablate by epicardial puncture, I will not do it because it will be very difficult to perform this line blindly with a mapping system. I don't know if I answered your question, but that was how the situation started.
Because, Carl, I think that nowadays when we have a pulse field ablation capacity, so you can avoid phrenic, you can avoid SVC stenosis, and you can be very selective in terms of sinus node ablation.
Yeah, that was my question or comment.
Oh,
and you
sorry.
will see, if you stay with us, Carlo, you can see one case now.
If you allow me to answer you, because of course we had these tools in our lab also, and that's very interesting. If true, we perform a redo. Sometimes the line are not complete, and thanks to the PFA, we could provide a complete line. But honestly, the perception is that the PFA will not provide the same level of denervation. So we do here, it's the one ablation that we do not target only electrical circuit, that I will agree with you to use PFA, probably very safe. But there is something in this procedure that is relating on the local denervation of the sinus node. And at the moment, what we try is not reproducible with PFA with the tools that we have today. I don't know what will be the future, but that's what we face today. But thank you for your question, and we will see in the future if you're right.
We did some preliminary studies or ablations with pulse field, with solid tip at this moment, because we don't want to do too much damage with Affera, for instance, because it's a much larger footprint. And actually today, one of the cases we will see in the next half an hour or 1 hour will be a case of inappropriate sinus tachycardia, and then Victor will try to modify, according to your concept, to modify this input to and also SVC ablation. So it's evolving concept, and maybe in the future, like in the history of AF ablation, it started all from surgery, and maybe we move to endocardial lesions that with safer energy. Although I agree, on the other hand, that it spares nerves, so maybe it does not do the same job like surgeon. But we
No,
will
it's very
see.
exciting. But what I want to point out with our procedure, I think the first thing we figure out is that it's a combined problem. So we saw a circuit that probably involved to maintain, like the example that come to me is always about the slow pathway. So everybody has a slow pathway. Everybody has this extension of the sinus node. But I think there is a kind of a neuro modulation that has to activate the disease and also maintain the disease, because in many of the patients it's temporary, this disease. So I think what I want to point out is very important in our finding that we should not concentrate only on denervation. I think there is circuit that we have to target too, and I'm happy to see your approach on this light case.
Okay.